Hi, my name is Dr. Joshua Richter. I'm an associate professor of medicine at the Tisch Cancer Institute, Icahn School of Medicine at Mount Sinai, and the director of myeloma at the Blavatnik Family Chelsea Medical Center at Mount Sinai. Today I'm going to talk about bispecific antibodies in multiple myeloma. So I think we've all become very accustomed to the three core drug classes in multiple myeloma: the immunomodulatory drugs, derivatives of thalidomide like lenalidomide and pomalidomide, the proteasome inhibitors like bortezomib and carfilzomib, and the monoclonal antibodies like daratumumab and isatuximab. But one of the things that we've begun to understand is that as we're moving all of these drugs earlier on, in fact, with the current induction regimen of DARA-RVD, where we're using all three of these in our upfront therapy, to look beyond these core classes to help manage our relapse and refractory myeloma patients. And what has become the core of this are our BCMA directed bispecific antibodies and CAR T cell therapies. And of note, the bispecific antibodies are near and dear to me because in the United States, more than 80% of myeloma is treated in the community, meaning that many places will not have the facilities or ability to give CAR T cell therapy. But bispecific antibodies, being off the shelf, can really be administered in almost any hematology and oncology practice and are quickly becoming one of the key management strategies of relapse and refractory disease. So at the moment, we categorize our bispecific antibodies into two groups: the BCMA bispecifics, of all of the ones on the left hand side of the screen, and the non BCMA targeting bispecifics on the right hand. Now, this data is moving very fast, so depending upon what time you're listening to this, some of these may or may not be approved. At the time of this recording, there are two FDA approved BCMA targeting bispecific antibodies, teclistamab and elranatamab. However, the middle drug, linvoseltamab, is currently in front of the FDA, and we anticipate FDA approval in August or September of 2024. Now, again, all of these drugs have two arms. One arm has BCMA, which is B cell maturation antigen, CD269 for people who like CD numbers, and that arm attaches to the malignant plasma cell. And the other arm is CD3, which attaches and activates your own endogenous T cells. And basically, I call it the Thunderdome of myeloma. Two cells enter, one cell leaves, and you have the T cell attack the myeloma cell. Now, we're used to FDA approvals across the last decade and a half at the end of myeloma therapy with doublets like pomalidomide and dexamethasone, carfilzomib and dexamethasone, with response rates ranging from around 22 to 30%. However, we now are looking at bispecific antibodies in late stage myeloma having single agent activity with response rates between 60 and 80%. These are unprecedented levels of response in a very heavily refractory groups of patients. Now, we also have the non BCMA bispecifics. Still, we have CD3 as the arm that attaches to and activates the T cell, but the arm that engages the plasma cell, we have two different key targets. One is GPRC5D, and GPRC5D, just like BCMA, is ubiquitously expressed on all plasma cells. And we currently have the FDA approved therapy of talquetamab. And then we have an additional bispecific antibody target that's still in clinical trial called cevostamab. This targets FCRH5, another antigen that's widely expressed on plasma cells. And again, these two drugs also have been showing response rates of greater than 60%, leading us to be very encouraged. So the first approval we had for a bispecific antibody came with teclistamab, and this is data from the Majestic 1 study. And essentially, we recognize that anytime you activate T cells, you run the risk of the side effects like CRS, which is cytokine release syndrome, or ICONS, the immune effector cell associated neurotoxicity syndrome. We see this in CAR T cell therapies after we infuse the T cells. But one of the strategies to mitigate these side effects is to use a step up dosing strategy. And we see that here with teclistamab, where we first give a low dose, 0.06 mg per kg. And then 48 to 72 hours later, we give the next dose, zero point 0.3 mg per kg. 48 to 72 hours later, we give the final dosing of 1.5 mg per kg, with hopes that we can gently ease the patient's immune system in to fighting the cancer cell. Because ultimately, myeloma, like everything else, is all about Goldilocks. We don't want the immune system porridge too cold where it's not fighting the myeloma. We don't want it so hot that they have untoward toxicity. And again, with this study, which showed teclistamab monotherapy in very heavily pretreated myeloma patients, showed an overall response rate of around 63%. And it's not just that these are high responses, but we can see here on the swimmer's plot, these are quite durable remissions. And at 12 months, we saw a 68.5% rate of still being in remission, which is very impressive considering that in heavily refractory myeloma patients, and we can extrapolate from the Mammoth trial, which looked at response rates and survival of patients with triple class refractory myeloma. When you become pentarefractory, so refractory to lenalidomide, pomalidomide, carfilzomib, bortezomib, and daratumumab, the Mammoth study showed an overall survival rate of around 5.6 months. That's overall survival. Here, in a similar type of patient, we're seeing the majority of patients still just being in remission at 12 months. So these are absolute game changers for heavily relapsed myeloma. When it comes to safety, the big issues are the acute toxicities and the delayed toxicities. From an acute toxicity standpoint, this is what we deal with as we're stepping up the dose with initial dosing. So these are things like cytokine release syndrome and ICONS, as well as cytopenias. Long term, one of the big issues we worry about are infections, because with bispecific antibodies, and very specifically the BCMA bispecific antibodies, there is multifactorial immune suppression. Number one, you get neutropenia. And we all recognize neutropenia puts you at risk for neutropenic fever and higher rates of complications with infection. As this drug targets BCMA expressing cells, you kill not only plasma cells, but some lymphocytes, and hypogammaglobulinemia rates are extremely high. Three-quarters of patients will become hypogammaglobulinemic. But the additional level of immune suppression is T cell redirection. Remember that you have T cells that are designed to fight bacteria and viruses. And when this drug is saying is, nah, come over here, stop minding the shop. We need you over here to attack the cancer. And that means that there's not as many people minding the shop. So it's multi layered immune suppression. So infection prevention and infection treatment are some of the core strategies towards improving overall outcomes by giving prophylactic regimens such as intravenous immune globulin, prophylaxis against HSV, and prophylaxis against pneumocystis pneumonia.
Just kind of curious in terms of that's really a high number of COVID deaths. Was this sort of during the pandemic? And do you think that there's still as much of a COVID issue?
So it's a really great question. The short answer is yes. The majority of these studies were initiated just prior to the COVID pandemic, but it is multifaceted. So it's not as much of an issue nowadays where we have better vaccine strategies and most of the strains are not quite as virulent. However, we did some internal studies, and the two biggest predictors of lack of a myeloma patient being able to engender an immune response to a COVID vaccine were anti CD38 therapy, drugs like daratumumab and isatuximab, and BCMA based therapy. So these drugs very much hinder the ability to form new antibodies against COVID.
Interesting. Please continue.
Thank you. So, one of the other big questions is what happens when we sequence BCMA therapies? Now that at the time of this recording, we have two BCMA bispecific antibodies approved. We have two FDA approved CAR T cells approved that target BCMA. At the moment, we don't have the antibody drug conjugate belantamab mafodotin approved, although it was previously approved in the DREAM 2 study, then taken off the market after DREAM 3 read out. But with the two phase 3 studies, DREAM 7 and DREAM 8 being positive, I do think there's a good chance we'll have belantamab mafodotin come back into the armamentarium of myeloma. And what these subset analysis look like is when we use sequential therapies, so teclistamab after either a CAR T or an ADC, we still have significant response rates. You do lose about 10%. So if the original response rate was around 63%, if you had a prior CAR T or a prior ADC, you now drop to the low to mid 50 percentile in terms of responses. The second BCMA bispecific that was approved was atimab. This is another BCMA CD3 based bispecific with very high levels of response rate. In fact, many of the effect numbers and the toxicity numbers are quite similar to teclistamab. There are some differences in terms of the drugs. One is that this is fixed dosing as opposed to weight based dosing. There's also a shorter step up and shorter hospitalization that would be needed for elranatamab. So we're talking around 5 days instead of 7 days. So there may be some subtle advantages there based on patient and institution preference. But overall, when we're evaluating the data in terms of efficacy and toxicity, they're very, very similar. Similarly, group of very heavily pretreated myeloma patients, similar response rate around 64%. And then a swimmer's plot again demonstrates that patients, even a year out, are doing quite well and maintaining their responses, even with patients with very heavily pretreated pentarefractory disease. Again, the median duration of response from Kaplan-Meier curve, 17.1 months. Again, for someone who has seen the three core classes of myeloma therapy, these are extremely impressive response rates. In terms of adverse events, similar profile to what we see with teclistamab, where we see the initial rates of CRS ranging from around 50 to 80%, comparing just a grade 1 to all comers. We typically treat this with drugs like tocilizumab and steroids. And again, because we're attacking BCMA in the same way, same acute and long term risk of infections will apply. Now, we do have follow up data from the Magnetism 3 study evaluating elranatamab. And this is data that ultimately did lead to the approval, published by Alex Lashokin of Memorial Sloan Kettering. And again, the majority of these patients did not have prior BCMA, but some did in different cohorts. Overall, progression free survival rates are quite impressive. And one of the things that we do see that dovetails with our CAR T therapies are that patients who achieve those really deep remissions, those CRs or better, complete response or better, those are people that really seem to have this unbelievably durable remission rate that seems to just last and almost have a real tail on the curve. It's probably not a true tail, but at the moment it is quite flat, and we're very encouraged by that data. In terms of toxicities, again, with the more mature data from Magnetism 3, we see, again, the similar response rates of cytopenias that are easily managed, as well as infection rates. The one thing to note is that although cytopenias can be seen early, we do tend to want to avoid white cell growth factors during the step up period because white cell growth factors can actually propagate CRS. So if you have someone who's in between the first and second step up dose and they are neutropenic, you may want to avoid filgrastim as that may precipitate your CRS event. Linvoseltamab is another BCMA bispecific, currently in front of the FDA. We're hoping for approval in September of 2024. This is another highly active BCMA bispecific. One thing that is distinguishing about this is the ability to officially extend out the dosing interval. Once you reach week 24, patients who achieve the VGPR or better were able to be dosed on a monthly basis, which, again, for patients who've had multiple lines of therapy, often having myeloma for years, it's a very patient friendly way of administering a highly effective drug to only have to come in once a month for administration. Now, again, we can't compare trial to trial because, as we talked about before, when trials were done during the COVID pandemic, of course, we're going to see higher rates of infection. But what we see so far is some of the highest rates of an off the shelf therapy in myeloma ever, with an overall response rate for linvoseltamab at 71%. And with CRS rates that were actually some of the most impressive in class, only in the mid 30 percentile, compared to some of the other BCMA bispecifics, which may be as high as 60 to even 80% rate of CRS. So, again, one of the things that we're striving to do is take therapies like this that are heavily utilized in the academic setting and making them equitable across any site. I think we've overcome a lot in terms of community administration, where we made that big shift in the oncology world from classical chemotherapy to the checkpoint inhibitors. There was some pushback initially, all different adverse event profile. And now you go to any community oncology infusion center and, so many people are receiving checkpoint inhibitors. I think that there's this next kind of gestalt switch of getting these immune therapies in the community. But I think as long as we work together, these are off the shelf therapies that can be administered in the community, providing high efficacy rates to our patients with multiple myeloma. And again, the pattern of CRS here is fairly predictable. It tends to come around 10 to 14 hours after the first dose. which usually means when the dose gets administered in clinic, I get a phone call somewhere around midnight that the patient is having their CRS. But the majority of this is going to be grade 1 and grade 2 and easily squashed down by giving a dose of tocilizumab or a few doses of dexamethasone. We typically dose dexamethasone around 10 milligrams. You can give it up to Q6 hours. Um, as an additional bispecific antibody that's currently under clinical trial, alnuctamab has become a very key drug of interest because of its different binding and its different affinity to treat some of the more resistant abnormalities in the BCMA binding area, that this may be one of the more potent drugs to use down the road. And again, so far we've seen some wonderful data published from Nofar Bar, looking at response rates that mimic what we've seen with teclistamab and elranatamab, with response rates around 63 to 69%. Again, in the swimmer's plot, this has become the standard now with bispecific antibodies, that we see patients who have had all of the classic therapies now having these very durable remissions extending beyond the year. And in a world where the goal of myeloma is to kick the can down the road so far, you get them to another therapy or another trial or fingers crossed the cure. These drugs are really getting our patients much farther down the road than many of the therapies prior. Now, switching gears for a moment to the GPRC5D antibodies. And although we have one FDA approved anti GPRC5D antibody, talquetamab, there is an additional one that has already gone far into its phase 1 studies, furimtamig. And so far, we've seen very high response rates, even in patients who've had prior BCMA therapy with these drugs. Because it's important to note that as we talk about BCMA, GPRC5D, and FCRH5, these are all expressed independently on the plasma cells. So you can have a patient blow through a BCMA therapy and then still express and respond to an anti GPRC5D based antibody. Now, this really got its approval based on HHRE study, the Monumental 1 study, and this evaluated talquetamab at two different doses: 400 micrograms administered weekly, or the 800 microgram dose administered every other week. In both cases, these were heavily pretreated myeloma patients who had progressed beyond all of the standard types of therapy in our armamentarium. And we can see here extremely impressive response rates, either at the 400 or 800 microgram dose, of around 73 to 74%. Again, in very heavily pretreated patients, this is so impressive to us and a really important tool in our toolkit to treat these patients. Now, again, just as what we've seen in Magnetism 3, the patients who achieve those deep remissions, the CRs, those are the people that tend to have the really incredible duration of remission. And you can see here, comparing those who got CRs or not in both dosing strategies, had very impressive and very durable remissions. Now, the question is always, what patients who had prior T cell redirection therapy, either prior CAR T or prior bispecific antibody? And in this subcohort, we see here, just as we saw previously, about a 10% declination in overall response rate. So if the overall population was around 73% with talquetamab, it drops to around 63% for patients who've had prior T cell redirection therapy, either with a CAR T cell or a bispecific antibody. In terms of adverse events, obviously we need to talk about CRS and ICONS. CRS is very similar to the bispecific antibodies that target BCMA, that we do see around 60 to 80%, depending upon the patient. Again, the majority of this is grade 1 and grade 2 and very easily managed. ICONS tends to be a much rarer event in bispecific antibodies as opposed to CAR T. It may have to do with the fact that you're stepping up the dose and mitigating the more severe cytokine release, whereas CAR T, you give the entire cell dose at one time and you get that big spike. The other toxicity worthwhile to note is that GPRC5D is not as expressed as much on other immune cells like BCMA. So you preserve CD19 positive B cells, you have less hypogammaglobulinemia and therefore fewer infections. But GPRC5D is expressed on the squamous epithelium of the hands and feet and the lining of the oropharynx and salivary glands. So you can get a desquamating rash, which kind of reminds me of the old capecitabine rash that patients used to get. Also, dysgeusia and anorexia are a side effect of this type of therapy. Cevostamab targets FcRH5, and although not yet FDA approved, is in ongoing studies and a very interesting drug, as again, this is expressed independently of BCMA and GPRC5D. And there were a couple of novel approaches of this study, the CAMEL 1 study. One of them was giving prophylactic tocilizumab. We recognize that tocilizumab, the anti IL-6 monoclonal antibody, is essentially the first line of therapy to manage cytokine release syndrome. So, what was done here was what was done in prior CAR T studies, such as some of the Zuma trials. What happens if we give it prophylactically to kind of head off CRS at the pass and not let the patients undergo it? And what we saw here was a significant decline in CRS rates in this study from around 91% down to just over 38%. So a significant improvement in CRS. But then we always have to ask the question, well, if you're blocking IL-6, are we hindering our efficacy? And although, again, the numbers here are not tremendously large, so far the answer is no. Again, this is patients who were treated up to 90 milligrams of the drug, and although we don't yet have an RP2D, my guess is that the RP2D is a three-digit number. So this is probably not the phase 2 dose. But even at 90 milligrams, we saw a higher response rate in patients who received prophylactic tocilizumab versus those that did not. So I think one of the ways that we're going to try to get some of these drugs into our community centers is by considering prophylactic tocilizumab-like approaches. For example, in one of the Majestic studies, it brought the CRS rate down from 76% down to 25%. So the ability to not have to admit all of these patients and get this in the hands of every center that we can. The other interesting approach was fixed duration. In the relapse setting of myeloma, all of our therapies are given till progression or intolerance, which can be quite a lot for patients. Even those who achieve great remissions and tolerate it well, they need to keep coming in to receive therapy. Cevostamab trials, and including Furimtamig trials, the drug is given every 3 weeks for a total of 17 cycles, which rounds out 1 year of therapy, and then we stop. And in this trial, we actually have the ability to retreat patients at the time of relapse. And what we noted was that any patient who completed the 17 cycles and had a stringent CR or better, they have not yet relapsed. We have a number of patients 2 and 3 years off of therapy in remission, and again, starting to incorporate MRD analysis, which has recently been approved by the FDA to incorporate in trial design, may be a pathway to figure out, again, Goldilocks. Not giving too little therapy, we don't control the myeloma, but not just keeping everyone on therapy indefinitely. So in myeloma, we always take drugs, approve them towards the end of the line, and then we move it further up and add combinations and what can we achieve. So we'll go through a little bit of the combination data. And here's some data from Majestic 2 combining teclistamab with daratumumab. And now we see response rates in patients with 1 to 3 prior lines of therapy of over 93%. Now, one of the things of concern is that we talked about the two biggest predictors for not developing an immune response to COVID 19 are anti CD38 therapy and BCMA therapy. And that's exactly what we're giving here. So, although this regimen is highly efficacious, we do have to give pause and note that the infection rates were quite high with this. And it's something to really consider. Even looking at this, 15.6 patients, again, small numbers, had grade 3, 4 pneumonia. This is something we really need to keep an eye on. And of course, one of the really great interesting approaches would be to combine talquetamab and daratumumab, where because the GPRC5D targeting talquetamab has less in the way of infections, one of the treatment combinations we're very excited about is the TRIM2 combo of talquetamab and daratumumab. And we see here, with given the 800 microgram dose, overall response rates of 84%. And even though high response rates in patients who had prior T cell redirection therapy. So, in myeloma, we're always trying to find out who is the best dance partner. Drugs want to find their favorite dance partner. And I think, daratumumab loves pomalidomide in the early relapse. They like to dance together. When trying to figure out what dance partner for a bispecific daratumumab is going to want to hang out with, I think this type of data, daratumumab and talquetamab, is going to be a very powerful and well tolerated regimen. Now, in addition, data that was recently presented by Jeff Mattis is the Monumental 2 data combining talquetamab and pomalidomide. And this is a really interesting approach. And again, response rates here of almost 94% in the 400 microgram dose. And the best thing here is that the pomalidomide is not there for cell kill. So you don't need to give the 4 milligram dose that we commonly think of to kill myeloma cells. We're using it as a T cell modulator to enhance a T cell response, almost like giving a checkpoint inhibitor on top of it. Remember, these are immune modulatory drugs. So here we usually give 2 milligrams, not enough that we give higher cytopenias, not enough to give cell kill, but enough to kind of activate the T cells and push them as talquetamab is doing it. And we're seeing really high response rates. And then, of course, the American adage, if a little is good, more is better. What about giving two bispecific antibodies at the same time? And this is what we're seeing now with the Redirect 1 study combining both teclistamab and talquetamab. And yes, the response rates are extremely high, but there's a specific subset of patients that seem to be benefiting from this combination. Extramedullary disease, plasmacytomas that live outside of the bone, have become one of the hardest types of myeloma to treat. With response rates from most of our therapies, even if the response rates in the total population is 80, 90%, usually we see 20 to 40% response rates in our EMD patients. Now, in early data from the Redirect 1 study, we're seeing response rates in extramedullary disease of over 80%. So even though the toxicity here is not necessarily more than one bispecific alone, it is a lot of therapy. But we're starting to figure out who will probably need this combo. It's those patients with diffuse extramedullary disease. Now, again, we talked about infections as being one of the big toxicities, and we can see here from a listing of a lot of the different trials, the rates of grade 3 or higher infections. And note that in trials such as the Majestic 1, there were a significant number of patients, almost half the patients had big time infections. We have shown that if you give primary prophylaxis with IVIG as opposed to secondary, so with daratumumab, we don't give IVIG just because you're hypogamma-globulin, but if you're hypogamma and you get infections, much in the same way with CLL, then we add on IVIG. Both BCMA bispecifics, we give it upfront, primary prophylaxis. We showed a tenfold reduction in rates of infection. So very important to incorporate that in your prophylactic approach. And note that with some of the combinations like teclistamab and daratumumab, this can be even higher. This is a little bit of a busy slide, but there are some subtle differences in terms of timing of CRS between some of the different antibodies. We do see it. And then the other early toxicity we look for is ICONS, the immune effector cell associated neurotoxicity syndrome. This can be something as subtle as a headache, all the way to things like confusion and altered sensorium, or even seizures. Actually, what turns out to be a predictor of development of icons is micrographia and dysgraphia. So patients undergoing step-up doses for bispecifics every morning, we have a patient write the same sentence. It's usually, "I want to get out of the hospital now." And if you round on them in the morning and it's a little more illegible or a little smaller, be on the lookout for icons. And again, when we look at some of the bispecifics, the percentage rates of icons are usually in the single digits. It's usually very low in terms of neurotoxicity, but something to be aware of because remember, these are clinical trial patients. When it comes to real world application, where you don't have to fit every inclusion and exclusion criteria, we're going to put sicker patients on these drugs, heavier burden of disease, which predict for higher rates. So, something to be on the lookout for. And with that, I'll thank you very much for listening.